Good morning. On behalf of the Border Solutions Alliance and the West Big Data Hub, thank you for joining us for our lightning talk today with Stefano Bertozzi, Director of Alianza UCMX, the University of California System-Wide Programs with Mexico. Dr. Bertozzi is Dean Emeritus and Professor of Public Health and Management at the UC Berkeley School of Public Health. He worked previously with the Bill and Melinda Gates Foundation, the Mexican National Institute of Public Health, UNAIDS, the WHO, and the World Bank. This morning, Dr. Bertozzi will spend 15 minutes talking about COVID-19 in congregate settings. Then we'll take a few minutes for questions and answers. Stefano, I'll go ahead and turn the floor over to you. Thank you for joining us today.
Thank you so much for inviting me, Melissa. It's a pleasure to be here with you, and congratulations on this terrific project that you've got going. So I'm going to speak a little bit about some lessons from the US experience and California's experience in prisons and nursing homes. And much of what I'm going to show you is actually the result of a collaboration with Bree Williams and her team at UCSF, and I'm shamelessly stealing her slides that she presented on Monday at a talk in Australia, but it speaks to the work that we've been doing together. So what you see here, and I'll show you another picture as well, is a cell block at the San Quentin State Prison just across the bay from where I live. And you can see here that this is a very large cell block with 5 different rows of cells on 5 different tiers. The cells just have bars between the cell and this open atrium space here. And there are actually 2 sides of this. So this atrium wraps around, and this same 5 open tiers is reflected on the back side. So the cells essentially back up onto each other. So there are somewhere between 750 and 800 men that are in this one enormous space, which, although it's individual cells, because there's no separation between the cells and this large atrium, is essentially like one single dorm for 750 or 800 men. And we'll talk about why that's so dangerous. So what, if this would advance, as of the 2nd of September, a few days ago, we had almost 120,000 cases among incarcerated people in the US, almost 1,000 deaths, and almost 25,000 cases among staff working in the prisons. And of those, 67 deaths, and recognizing that some of the deaths, because obviously the staff are in the community, I suspect that the underreporting of COVID deaths in the staff is even greater than it is inmates. So I'm going to show you the example of San Quentin State Prison, which was built in the latter half of the 1800s. So it's a very old prison with the kinds of cell blocks that I just showed you. What happened in San Quentin was on the 30th of May, about 120 people were moved from Southern California to Northern California for their protection, because these were older inmates or inmates with underlying medical conditions who were in a prison where they couldn't be given their own cells. And so they were moved to San Quentin because the reception center, the place where new inmates come into San Quentin, had a number of extra cells open. And the idea was that by being able to put them into individual cells, they would protect these inmates. Unfortunately, they were cells in the kind of cell block that I just showed you. And so what happened is that as of the 12th of June, there were 16 cases. And we went in on the 13th to visit the prison and make recommendations about how to avoid a catastrophic epidemic. And we walked in to a cell block just like this. This might actually be Badger Block. I'm not sure in which of the cell blocks this photograph was taken. And we were like, oh my God, this is even though we understood that it had been done to try to protect those prisoners, this is the worst place to put prisoners who were potentially infected, because you can't isolate them from the other 750 people who are surrounding them in this essentially giant dorm. So you had very antiquated facilities, you had poor ventilation. You can see these ventilation vents on the roof that looks like nice modern ventilation, but those are just smoke exhaust system that was not being used. And you had limited staff testing, and you had very little limitation on staff movement between housing units. So even if you had an outbreak in one housing unit, there was a good chance it was going to be transmitted to other housing units. and unfortunately inadequate staff training. And then that was all compounded by the fact that you couldn't get rapid test results, and that San Quentin was seeing a 6-day delay in return of test results. So this is what was happening in California. And you could see here, this is the cases per 1,000 people. In the general population in California, it was about 6. It was already at that time not that far from 10 times as bad in the state prison system. And then along came San Quentin. And you can see what happened in San Quentin was this explosive super spreading event in the prison. And it is now the #1 largest outbreak in the United States, was the one that occurred at San Quentin. It overtook the outbreak at the Marion prison in Ohio. So we issued 2 days later some urgent recommendations, and I just want to summarize for you a couple of those recommendations, and we're going to post the slide deck. The slide deck is more complete than what I have time to tell you today. But the first one is, we need to get people out of prison. And the way to think about that is that some people sort of naively think that everyone who's in prison is in prison because they can't be safely in the community. In fact, that's a small minority of people who are in prison. Most people are in prison because they're doing their time. They're paying their dues in response to their sentence. Now, we could have a separate discussion about the ridiculously large number of people that we incarcerate in this country for ridiculously long periods of time, and how that disproportionately affects the African-American population. All of that is true. However, whether African-American or not African-American, there are very many people in prison who are not a danger to society if they were to be outside. And there's no reason why, even if we're going to force them to do their full time, that they have to do that right now in the middle of a pandemic. So the first lesson is, let people out of prison, because that protects the people that you let out during the pandemic. And it means that the people who are in prison are safer because there is space to keep them safe. So these are the kinds of conditions that we have people incarcerated in this country. Much of it is overcrowded. You can see this is a dorm setting, but this is a dorm setting for disabled people. So you can imagine that people with terminal cancer, people who are in wheelchairs, people who are multiple amputees, people with advanced disease such that they require walkers, these are not people who are likely to pose a risk, a safety risk, if they're released from prison during the pandemic. But even more importantly, they're people who are at much higher risk of severe complications of COVID. So you can see that as you're decarcerating, or as you're letting people out of prison, whether for good or temporarily, we want to prioritize releasing people who are at much greater risk of severe complications and death from COVID. So the foundational principles: we need to be able to physically distance within prisons. We need to be able to quarantine people who are exposed, and we need to be able to test and isolate people who are confirmed to be positive. And you can't do that without space. And in a crowded or overcrowded prison environment, you can't accomplish those things without releasing people and creating space. Now, the other thing is that people think of prisons as being places where people live in cells, but I showed you a picture of a dorm. That's a very common housing arrangement in many of our prisons, in fact, most of our prisons. And what we need to do is to recognize that when you put people in a dorm, that's like people being in a single household, except that if you have a household of 200 people, of even 800 people, as I showed you in San Quentin, what you're doing is you're creating a household that's gigantic and that enables super rapid spread within that household. So we need to minimize the number of people who live in a congregate setting. We wouldn't put people into households in the community that are 40 people households. We can't do that in the prisons either, because then you get very rapid spread within that household. Second lesson, we need to use medical isolation and quarantine in an ethical way that respects the right of those prisoners. They're not being punished and put into solitary confinement. But unfortunately, in many places, the cells that are available for quarantine and isolation are cells that are otherwise used for solitary confinement. The key is to do it in such a way so that it is not punishment. This is a solitary confinement cell, often referred to as the hole or ADSEG for administrative segregation or restrictive housing. This is where somebody is essentially being punished by being put into solitary confinement and having all of their benefits removed, their food supply, their television, their ability to contact the outside world, and to have video visits and all that kind of stuff. That's the opposite of what we want in a prison, because we want people with symptoms to volunteer their symptoms and agree to be quarantined and isolated. So what we need to do for people who are exposed or infected, we need to keep them away from others so that COVID won't spread. We don't want fear of isolation and solitary confinement to deter people from reporting symptoms, because that will worsen the outbreak. So we also can't use punitive isolation for someone who's sick, because that contravenes medical ethics, right? We want to do the opposite of punishing somebody who is sick. So the only way that medical isolation and quarantine should be the same as solitary confinement is that it's separating from those people from the general population. And let me just say that that means that if anything, we want to increase their access to family, to the food that they can order, to all of their benefits, so that people are encouraged to report, not discouraged from reporting. The third lesson is we have to remember that there are many, many people, tens of thousands in California, of staff who go in and out of prison every day. And those staff bring the virus into prisons. But when there's a catastrophic outbreak, they also bring the virus from the prison to the community. So prisons are not isolated from our communities. On the contrary, you can't keep a virus within the walls, and it's very hard to keep the virus outside of the walls. So we have to remember that community health is interconnected with prison health, of course, partly because prisoners come into prisons and leave prisons, but even more importantly, because staff every day go in and out of prisons. Now I want to switch in the last couple of minutes to mention nursing homes, because nursing homes have played an outsized role in the deaths in this country, because obviously they concentrate the people who are precisely those who are at greatest risk of developing severe disease with COVID and dying. And here you see a picture from the Houston Chronicle of people in a socially distanced way playing bingo in the hallway of a nursing home. What you can see on this graph is the cumulative coronavirus cases in long-term care facilities. I know this effort is interested in the entire border, but unfortunately on these graphs, the other border states with Mexico are not reporting cases, but you can see here the very concerning trend in California with the fastest rising number of coronavirus cases in long-term care facilities. And here you see California highlighted. Here you can see deaths in long-term care facilities. So fortunately, the increase in California was later than it was in some other states, and we're doing a better job at keeping people alive, so the death rate is not as great, but you can still see here that California's death rate is climbing alarmingly in long-term care facilities. Now, you don't see long-term care facilities among the largest outbreaks, just because long-term care facilities don't have thousands of people in them individually. So, but the lethality is very high. And you can see here that over time, close to 50% of deaths in the country have been deaths in long-term care facilities. So although we've seen these enormous outbreaks in prisons, we've seen most of the deaths occurring in long-term care facilities. It's just that there are many more of them that are being affected. And with that, I'm almost out of my 15 minutes, and I will stop. As I mentioned, I'm going to share this slide deck with you, and the slide deck includes a number of other slides and other lessons that I didn't have a chance to speak about, but you can also learn more about the work that we've been doing at Berkeley with Amend at UCSF by going to their website at www.amend.us. And let me turn it back to Melissa. I'll leave that up on the screen for a minute, and then I'll stop sharing so we can see each other better. So Melissa, back to you.
Thank you so much, Stefano. I have a couple of questions for you, but before I begin, I'll like to ask if our audience has any questions that they would like to pose. If so, you can use the Q&A function at the bottom of the screen, or you can raise your hand and I can turn the microphone over to you. If not, I do have some questions that I'd like to delve into. You know, as you discussed, both the assisted living facilities and the prisons. Of course, in our communities, we have other congregate settings like university dorms, like migrant shelters and homeless shelters. And so I'm sure many of those principles extend across those other spaces. But as you were speaking, it occurs to me that there are many more disincentives than incentives for people in those settings to self-report that they might be feeling ill, especially workers who might be hourly workers and who need to be able to come to work for their own economic circumstances and families. And so could you expand a bit on how we can think about using data or encouraging people to transparently report their own symptoms in a way that can better help us identify and get ahead of an uptick in cases in these kinds of spaces?
Well, Melissa, you touch on a number of important issues in that question. Let me start with the issue of sick leave and benefits for staff. If you have staff working in any of the congregate settings that you mentioned, and of course you're in San Diego and at the border, and we're very concerned about the migrant detention facilities. Anything that I said about prisons obviously applies to any detention facility, but to the extent that I'm worried about them in California at least, we have a system which is that the health system in the California prisons is under federal receivership. It operates with an extraordinary degree of transparency. Anybody can pull the website up and see on a daily basis what's happening with COVID in every single prison in the California state prison system. As you know, that's not the case with the immigrant detention facilities, and I'm very worried about the lack of transparency and the lack of response to mitigating the effects of COVID in those facilities that I've seen thus far. So let me start with the staff issue. It is terrible to have a situation where staff are not fully protected in the case of that they become infected or even have symptoms, and feel that they need to report to work anyway in order to be able to make money. We need a system of sick leave that is compensated, where people continue to receive their salaries until they can be demonstrated to be recovered from COVID. We want them to be able to report not just symptoms, but also exposure. If they have COVID in the household, we want to be able to keep them separate from the inmate populations, because I've shown you how explosively it can spread in these congregate settings. So we don't want anybody who's symptomatic, anybody who's infected, or anybody who's been exposed to be in contact with congregate settings until they have gone through a quarantine period and can be shown to not be infected and therefore infectious and potentially risking other people. Now, that also is true that because people go in and out, and it's impossible to be 100% vigilant, that they need to be especially careful about personal protective equipment while they're in the congregate settings to prevent transmission to the people inside. In certainly prisons and jails, traditionally people think of the staff being at risk from prisoners, not prisoners being at risk from staff. Now, of course, both of those things can happen. Violence can happen in both directions, as we all know. But in this case, it's overwhelmingly the case that the people who go in and out every day, meaning the staff, are much more dangerous to prisoners than prisoners are to staff, because they're incarcerated and much less exposed, except to people who go in and out of prison. Since we've shut down visitors for a long time, in-person visitors, that's obviously no longer a route of transmission. So that's really important. And the other thing that's really important is testing and rapid turnaround, so that we have early detection of infections. So as soon as somebody's symptomatic or there's a possibility of an outbreak, you want to be able to test immediately, and you want to get those test results back immediately so that you can respond. If you have test results that are coming back 6 days later, that person is no longer infectious. You've missed your entire opportunity to interrupt the chain of transmission from somebody who is infected to other people who are not yet infected.
Thank you. That was actually very similar to the second question that I was going to ask you. Our data challenge participants are really focusing on data in terms of the data that we need to analyze or gather to make sure that we're mitigating risk and understanding risk. And so perhaps you've already touched on this, but if there's anything that you'd like to expand on, if you had a magic wand in these settings, what is the data that you would most want to have access to and in real time to be able to keep populations and staff safe?
Well, since you asked, I can't help but point your challenge participants to the California State Prison COVID website. And can you see my screen now?
We can, yes.
Yeah, so what you can see here is just the first page, and there's many other pages within here. You can see here a listing of every prison and how many inmates are currently active with COVID in each of those individual prisons, how many have been released while active, how many inmates in that prison have resolved their infection. You can see here that San Quentin is at the top with 2,147, but San Quentin today has only 10 active cases. And then you can go in and drill down into any individual prison you want. Now, this one happens to be Folsom State Prison. Folsom State Prison was built about the same time as San Quentin and is equally dangerous with these enormous cell blocks that function like large dorms. And you can see that they've had an outbreak at the end of August, but because of the experience in San Quentin, rather than being over 2,000 cases, they've been able to contain it much better than they did at San Quentin. It's still bad, but not nearly as bad. But you can pull this up for any prison in the system. And you can go and look at employee status. You can do lots of things on here. And this is only the COVID website. There are data on the CDCR website where you can look at dashboards for all the health conditions. And you can see, for example, in each of these prisons, how many people have diabetes. It's very different from prison to prison. And you can imagine what their differential levels of risk are. Now, I would encourage your students, obviously I encourage other institutions to have this level of transparency, but I also would encourage your students to look for these kind of data if they're interested in congregate settings and see which ones have data that they could work with. And one obvious one is the institution where you are, Melissa, because UCSD, I think, is leading the UC system in terms of its testing data and its aggressive efforts to understand the spread of the epidemic on campus. I can be a little bit proud of Berkeley, but I think that you at UCSD are leading the system.
Well, thank you, Stefano, for sharing that resource. We'll add that to our repository of data sources and resources. And I think that that's a great tool for students who are working on projects in these spaces. Let's see, we have something. There we go. All right, thank you.
I just put it in the chat for you.
Wonderful. All right, well, with that, I think we've come to the end of our time today. Thank you again for sharing your insight and knowledge with us, and thank you so much for participating.
Well, it's my pleasure always. Thank you so much for inviting me, Melissa. Take care.
Bye-bye.